Good evening, everyone. Welcome to the guided poster tour number 3, Prevention of Mother-to-Child HIV Transmission. And I'm your moderator, Linda Stranix-Chibanda, working and living in Zimbabwe. We have a very exciting lineup today, which feeds on so well from the presentation we had earlier from our UNAIDS speaker, who reminded us to close the treatment gaps for pregnant women in order to realize our aims to eliminate pediatric HIV and mitigate the impact of the COVID-19 pandemic on our health delivery systems. And we have 5 speakers today covering different aspects of EMTCT. Our first speaker today is Jessica Lee, who is a medical student who lives and works in Vancouver, and her presentation talks about the cascades of care for preventing vertical HIV transmission in Canada. So I'm going to hand over directly to Jessica, and she's going to take us through her presentation. If we could share her poster, please. Thank you.
Hi, thank you so much, Linda. Hopefully everyone can hear me. Thank you for this opportunity to present on the cascades of care for preventing vertical HIV transmission in Canada. So we know in the era of combined antiretroviral therapy, vertical HIV transmission has declined substantially, but missed opportunities still remain a concern for vertical transmission among pregnant women and their infants. So the cascade of care is the tool that estimates engagement in care and encompasses a continuum of services from diagnosis to virologic suppression. So this study investigated the cascade of care indicators from mother-infant pairs in the Canadian Perinatal HIV Surveillance Program, or CPHSP. So the CPHSP is an active surveillance system that collects data on vertical transmission across all 13 provinces and territories in Canada at 23 participating sites. It captures the vast majority of pregnant women living with HIV in Canada. The current analysis was restricted to live infants born to women living with HIV in Canada from 2008 to 2018. Measures of success included maternal diagnosis prior to the second trimester, initiation of antenatal antiretroviral therapy, or ART, before the third trimester, an undetectable viral load near delivery, infant prophylaxis, finalization of infant HIV status, and linkage to care within 1 year if found to be infected. Linkage to care was defined as having a recorded immunological or clinical status as evidence of care. And proportions were presented at each step in the cascade of care and then further stratified by infant year of birth, exposure risk category for the mothers, and infant province of birth. So a total of 2,651 mother-infant pairs were included. Of all women, 80% were diagnosed prior to the second trimester, 78% started ART before the third trimester, and 80% achieved an undetectable viral load prior to delivery. Among all infants, 91% received appropriate prophylaxis, and 85% had sufficient testing to finalize their HIV status. Among 37 infected infants, 92% were linked to care. Analysis by infant year of birth showed an increase in the proportion of women achieving an undetectable viral load near delivery from 67% in 2008 to 88% in 2018. When stratified by infant province of birth, Alberta, Saskatchewan, and Manitoba experienced the lowest rates for maternal engagement in care indicators. When stratified by race and ethnicity, Indigenous women in Canada experienced low proportions in diagnosis before the second trimester, initiation of ART before the third trimester, and undetectable viral load. And then finally, when stratified by exposure risk category, women who reported injection drug use had the lowest engagement in care by maternal measures. So in conclusion, this population-level analysis demonstrated promising trends of maternal and infant engagement in HIV care within a Canadian setting. However, gaps in care remain a significant concern for certain populations of pregnant women living with HIV and also for their infants. So as Canada strives to improve the continuum of HIV care, these findings may inform targeted strategies to reduce vertical transmissions and to optimize continuity of care for both mothers and their infants.
All right. Thank you, Jessica. All right, I have a question for you. And while I'm asking that, if I could ask the other speakers to come on stage with your video, please. Jessica, I noted that different provinces of Canada had different rates of maternal engagement. And I'm curious to hear your views on what factors could be driving those differences across the provinces. Thank you.
Yeah, thank you. That's a really good question. I can try to answer it to the best of my abilities. So I think there's different epidemiology in terms of women living with HIV and their infants across the different provinces in Canada. So for example, here in British Columbia, it's primarily driven by gay bisexual men who have sex with men. In places like Saskatchewan, for example, that's primarily a population where you have Indigenous women living with HIV and also injection drug use. And in previous studies, in Canada, the US, and Europe, we've seen that in the IDU group, the findings of later diagnosis and initiation of ARV antenatally have been shown in that group, and substance abuse is a predictor of later diagnosis, leading to suboptimal ART and also vertical transmission. So this risk group has been associated with inadequate natal care and HIV testing for delivery. So I think given the different epidemiology of who has HIV across the different provinces, that could be a factor in the different rates that we see here. Also just mention that there are different women-specific care and clinics across the different provinces, and so that may be playing a role in reducing the barrier to access, engagement, and care, when such a women-specific clinic is available in the provinces. But finally, it's not explanations for the lower engagement in places like Saskatchewan or among Indigenous women can't fully be determined with just available data here. But some of the possible explanations.
All right, thank you. Thank you. All right, we're going to move to our next speaker now. And that's Cosima Lenz, is currently the Associate Officer for Adolescence and Youth on the Technical Leadership and Program Optimization team at EGPAF, and who alongside her colleagues completed the opportunity analysis on HIV risk and acquisition amongst pregnant and adolescent girls and young women in ANC services in 10 African countries. So over to you, Cosima. Thank you.
Thank you so much, Linda. So this poster, I'm not sure if you can see it, but it presents an analysis that was undertaken earlier this year that looks at HIV risk and acquisition among pregnant adolescent girls and young women between the ages of 15 and 24 in antenatal care services across 10 African EGPAF presence countries. The rationale in completing this analysis was the recognition that HIV transmission among AGYW in sub-Saharan Africa remains high, as well as rates of unplanned pregnancy. And in line with that, acknowledging that there's an increased risk of HIV acquisition per unprotected sex act during pregnancy and the early postpartum period. So we analyzed routine aggregate program data to understand HIV trends and potential prevention opportunities among pregnant adolescent girls and young women and antenatal care clients in our programs. We looked at the number and proportion of HIV positive pregnant women in ANC and women attending PMTCT services from October 2018 to December 2019, so about a 15-month period, and disaggregated this by country, by the 10 different countries, and age groups, focusing on older adolescent girls, so 15 to 19, young women 20 to 24, but also did look at adult women 25 plus. So the key findings of this analysis include that we found proportionally adolescent girls and young women between the ages of 15 to 24 make up almost half of all ANC clients, so about 46%. And some countries like Lesotho and Mozambique revealed this proportion to be above 50%. But overall, all countries had a high proportion of AGYW as new ANC clients. And of those entering ANC with a known HIV status, which was close to 99%, HIV positivity was associated with age. So with 2.6% of those aged 15 to 19 years being HIV positive, 5.3% of those 20 to 24 years being HIV positive, and 9.4% of those aged 25 and older being HIV positive. But we did see that the majority of those with a confirmed HIV positive status were receiving ART. So 95% of those between the ages of 15 and 19, and 97% of those between the ages of 20 to 24. And of the 10 countries included in the analysis, at the time we had done this analysis, 5 offered PrEP to this population. So some key takeaways in terms of this analysis: while the rate of HIV positivity increased with age, being highest among those older than 25 years, a significant proportion of adolescent girls and young women were HIV positive, and this ranged from a low of 0.7% in low prevalence countries like DRC to 17% in high prevalence countries like Eswatini. So prevention services like PrEP for adolescent girls and young women, who make up nearly half of the ANC and PMTCT clientele, and the majority of whom will be HIV uninfected, were relatively limited. So there's this real need for these services to be scaled up, especially in high prevalence settings. So thank you so much.
Excellent. That's very interesting. And it's an area I'm very, very interested in myself. You talk about ANC being an ideal environment for pushing prevention in young women. What is it about ANC that makes it so?
Yeah, that's a great question. I think the fact that ANC sort of presents this regular opportunity to engage with pregnant women is an opportunity in itself. So these regular encounters with pregnant women experiencing with the health system and health providers at regular intervals throughout their pregnancy and the postpartum period is an optimal platform for integration, especially for prevention like PrEP, and also for family planning and other services in reaching these women, but also potentially an opportunity to reach their partners, whether that's through different testing modalities or treatment or prevention.
Excellent. Thank you so much. I think let's move straight on to the next presenter, and then we'll loop back for more questions to the group. So I'd like to introduce you to our third speaker in the poster session, and that's Grace Naikazi from Uganda. And Grace is going to talk to us about continuous quality improvement, improves retention of clients in prevention of mother-to-child transmission of HIV program in Wakiso district of Uganda. Grace, over to you. If you could share this poster, please, for us. Thank you.
Thank you so much. This is Grace from Uganda, Grace Naikazi. Thank you. We see that, can you be able to hear me?
Yes, we can. Thank you.
Mother-to-child transmission of HIV is still a challenge, and we see that 90% of new HIV infections are still there in children globally. Low retention in children, in pregnant and breastfeeding mothers, it hinders prevention of mother-to-child transmission efforts. So in Wakiso district, in December 2017, we saw that the retention was 61%. And that is in the supported sites. by Mildmay, Uganda. And we started continuous quality improvement interventions, and we can see that there was a gap in retention, and we evaluated different continuous quality improvement interventions. So the methods used, we assessed the data, 12-month data, but this is repeated support. And so the phone calls, we have peer mothers, the volunteers, and then also the follow-ups and home visits. But in all, we can say that the ART clinics were separated from OPD. So we realized that the whole PMTCT clinics were incorporated in maternity. That means that called for additional human resource. So we included midwife volunteers to support the PMTCT clinics in MCH. And with the existing strategies, that is when we saw an increment in retention. So when you go to the results, we see that the retention from the 51 supported sites was able to increase from 61% in October to December to 63 in the following quarter, because this indicator is reported on a quarterly basis every after 3 months. And we can see that there was a significant positive trend across the different quarters over the reviewed 2 years. And finally, we can see the retention steadily improved to 93%. But all in all, we can see that the additional human resource is key. We really need it in MCH to boost the PMTCT strategies amidst other interventions. Thank you very much.
Thank you. That's very, very interesting, Grace. And we're going to move straight into our next speaker in the interests of time. And we have Ms. Neary, who's a PhD student in the Department of Epidemiology at the University of Washington. Her abstract covers stunting in HIV-exposed, uninfected children. Over to you, Ms. Neary. We need to hear you. If you could press your sound.
Sorry, can you hear me now?
I can hear you. I've lost your video. There we go. There you go.
Thank you, everyone. My apologies for my technology mishap. So the primary objective of this analysis was to determine differences in growth between HIV-exposed, uninfected, or HEU, and HIV-unexposed, uninfected, or HUU children in Kenya. HEU children have poorer growth outcomes than HUU children. With the expanding population of HEU children globally and the long-term implications of growth compromise, it's important to determine population-level differences in growth between HEU and HUU children. So this was a cross-sectional, population-based survey enrolling mother-infant pairs attending 6-week and 9-month immunizations in 140 clinics across Kenya between July and December of 2013. Primary outcomes included weight for age Z-score, or WAZ, length for age Z-score, or LAZ, head circumference for age Z-score, or HCAZ, and we dichotomized all of these measures to include underweight, defined as WAZ less than -2, stunting, defined as LAZ less than -2, and low head circumference, defined as HCAZ less than -2. These outcomes were compared between HEU and HUU children at the 6-week and 9-month time point. Correlates of poor growth were assessed using generalized Poisson and linear regression models accounting for clinic-level clustering. Overall, 2,457 mother-infant pairs were enrolled, with 1,409 enrolled at week 6 and 1,048 enrolled at month 9 immunizations. Of mothers living with HIV, 64% received antiretroviral pregnancy, and 22% received AZT prophylaxis during pregnancy. Compared to HUU children at 6 weeks had lower mean WAZ and LAZ. At 9 months, HU children had lower mean LAZ and HCAZ compared to HUU children. Stunting prevalence was higher in HEU children, compared to HUU children at both time points. In multivariable analyses, HEU children had lower mean LAZ at 6 weeks and 9 months, and HEU children were nearly twice as prevalent to be stunted compared to HUU children at both time points. HEU children at 6 weeks had lower mean WAZ after adjustment, and at 9 months, low head circumference was twice as prevalent among HEU children compared to HUU children. So in conclusion, despite high maternal ART coverage, HEU children had poorer growth than HUU children in this large population level comparison in Kenya. Optimizing breastfeeding and nutritional practices in HEU may be useful to improve growth. And thank you. Yeah.
Great. That's quite disturbing to see the lingering effects that we need to continue monitoring. All right, we're going to hand over to our last speaker in this session, who is Barbara Burmen, a medical doctor and public health specialist with interest in HIV ops research, who's going to speak on the adoption of WHO HIV retesting policy for HIV negative women during breastfeeding period in 10 high burden Africa countries. Over to you, Barbara.
Thanks, Linda. Good morning, good afternoon, good evening. I'm going to speak about yes, an assessment of description of how WHO's HIV retesting policy for HIV negative women during the breastfeeding period was adopted in 10 high HIV burden countries in East and Central Africa. The motivation for doing this analysis was an assessment. We were looking at how to define HEU, HUU, and HEI children who are actually HEI children are well defined. So looking at the East and Central Africa belt, the countries that are represented in this analysis, the first graphic, you could see the high incidence countries represented by the dark maroon colors covers most of East and Central and South Africa. When looking at these countries, you could see the HIV testing is mainly around 90% for all these countries except Swaziland in this region. So the most women are tested for HIV during pregnancy. Looking at the next map, the number of women who are covered with ART coverage in pregnancy is also very high. But when we come to the inticity rate at the end of breastfeeding, it is not as encouraging as the other images. The motivation for looking at this was also looking at the period of which to which the infant is exposed to HIV. The longest period in regions where women are breastfeeding is during the breastfeeding period, which may go on for up to 24 months. So in the event of an undetected and diagnosed HIV infection, the likelihood of transmission from mother to child is likely to be very high. This is especially where women are tested once in pregnancy and declared negative and the retesting is not done. So this assessment was mainly an online search of guidelines that had been used in these 10 different countries. There were more countries in the initial analysis, but they were excluded because the guideline had to specifically mention that it was adapting the WHO 2016 guidelines, which were enacted in 2015 and have the exact wording to guide its recommendation, guide its implementation. So when we're looking at the 10 countries, we had variations in the timing of the first test, the repeat schedule, the timing of the last test relative to the breastfeeding period, and also variations in partner testing. We had very low rates of partner testing, only 40% of the countries, and only one actually offered retesting at the same schedule at which is offered to the mother. Others say just encourage testing or offer testing for their partner. So we realize this is an online analysis, and after working in the HIV program in Kenya for a number of years, we appreciate that we have lots of other documents that come through, circulars and document letters and all sorts of details that come from the Ministry of Health to the clinicians that inform them that you're supposed to change some things that you're doing in the clinics, which it does not really get to the guidelines. So what is in the guidelines may not really reflect what is in the clinical practice. And there's also a time lapse between what happens in the clinic from when this guideline was implemented, as well as updates due to those documents I've mentioned. We do not know the rationale for which these different repeat testing schedules were used. We don't know why people chose 6 monthly, 3 monthly, similar to the general population, or during the breastfeeding period. And there's a potential difference between what actually exists in clinical practice and what's documented in the guidelines. So in conclusion, the HIV testing policies as documented in these guidelines for HIV negative breastfeeding mothers in these high HIV burden settings during the postpartum period are suboptimal for timely identification of new infections, and therefore implementation of interventions to prevent mother-to-child transmission. And this is further worsened by limited guidance on HIV testing for their sexual partners. So in recommendation, it would be useful if countries routinely document what guidelines they're adopting and have more or less uniform requirements for partner testing and schedule repeat testing convenient with other services, and this is currently ongoing. We often also recommend routine policy and practice assessments to align HIV health policies to country-specific HIV statistics and standardize policies through such assessments with a view to illustrate pertinent differences that may hamper HIV transmission efforts. I would like to acknowledge the co-authors and the institutions which supported the analysis that are presented. Thank you so much for listening, and over to you, Linda.
Great. Thank you so much, Barbara. We now can go into our question time. We've just got a few minutes left, and I have a question from Ms. Neary. Your current recommendations for mothers with HIV is to initiate lifelong ART, and breastfeeding continues for longer than it did in the past. If you repeated your data collection in the current era, do you think you'd find the same effect on infant growth? Thank you.
That's a great question. Can you hear me?
Yes.
Okay, awesome. So that's a great question. So during data collection in 2013, WHO recommended continued breastfeeding after 6 months during complementary feeding. However, only about 72% of HEU children were breastfeeding at 9-month immunization time point. And this was much higher in the HUU children. So this may be an artifact of prior recommendations. So it's a great question. In our analysis at 9 months, continued breastfeeding was associated with lower prevalence of underweight and borderline lower prevalence for stunting and head circumference. Today, with a continued emphasis on breastfeeding and infant and young child feeding strategies, we may expect better uptake of continued breastfeeding after 6 months among HEU, thus better growth among HEU. And although recent studies continue to show poor growth for HEU compared to HUU children, even among mothers with lifelong ART, suggesting that there are other correlates or cofactors to look at.
Excellent, thank you. I have a question for Dr. Burmen. You mentioned tailoring your retesting policies to match country-specific HIV statistics, but could you give us an example of the differences seen across the different countries and the different regions?
Unfortunately, it's a little difficult to have the temporal association between when the guideline was implemented, when the practices happened, and the actual MTCT rates, because we are looking at something within a timeline of about 30 months, 9 plus 24 months breastfeeding. What countries could do is look at the time at which majority of transmission occurs, especially based on the duration of breastfeeding for mothers. If mothers routinely breastfeed 1 year or routinely breastfeed 24 months, and tailor the HIV testing policies, especially at the end of breastfeeding to that. as well as encouraging partner testing. Thank you.
Thank you so much. And unfortunately, we've come to the end of our time. So we're going to have to thank all of our speakers. Well done. Fascinating data, and be very curious to see how your ideas develop further. Thank you to those who've joined us, and we're going to have to end this poster session now. Enjoy the rest of your day. Goodbye.